This conference will now be recorded.
Hello everyone, I am Dr. Juma Vishwas. I'm the mentor of MRCOG Health. Today I'm going to discuss a very important topic, that is CTG interpretation. This is the part of labor ward module, but is very important because I realized most of the students actually fail in interpretation of CTGs, and most of the students fails in labor ward module. So that's why I'm thinking that I'm going to take in a different sessions related to labor module, and I will also discuss few questions over there so that they're going to help you to pass in MRCOG exam. And you will see lot of EMQ in obstetric part in MRCOG part 2 from labor ward module and also from delivery module. So this is very, very important. You have to understand how we manage here in a labor ward, and what is the interpretation of CTG and how usually we interpret, and according to the interpretation how we're going to manage. So let's start with the CTG. So before discussing about the WHO CTG classification, you need to know and you need to understand what is the basic of cardiotocography or CTG, and what is the basic we actually see from each CTG. So CTG actually is a visual representation of the fetal heart rate and uterine contraction. That means that through the CTG, we will get two interpretation. One, we can get idea about the fetal heart rate. Another is that we will get idea about the uterine contractions. So these two things usually we see in CTG. So when we evaluate the CTG, we always follow one criteria that is called Dr. C. Bravado. Doctor means that when you see the CTG, you always need to look on that what is the risk, what is the conditions that actually needs the continuous CTG. So that means you have to determine the risk. That can be hypertension, that can be induction, that can be augmentation, anything over there. C means the contraction. That means you have to count the number of contraction in 10 minutes. That's the second thing you need to see. And the last things you have to see, that you have to look on the fetal heart rate. So when we see the fetal heart rate, the BRA means that you have to assess the baseline rate. V is variability, A is acceleration, D is deceleration, O is overall assessment. So this is an overall CTG interpretations you have to see. So if you anyone, even if you part 3 exam, if they ask you to interpret the CTG, always you have to follow Dr. C. Bravado. That is, determine the risk first. C is the contraction, BRA is the baseline rate, V is variability, A is acceleration, D is deceleration, O is overall assessment. So normally we don't do CTG in every cases. We only do the CTGs where there is any kind of risk. So what are the indications where we do the CTG? So it can be maternal, it can be fetal condition. So in case of maternal, if any kind of maternal medical disease over there, we do the CTG. For an example, if it is a preeclampsia or pregnancy-induced hypertension, diabetes on metformin or insulin, obstetric cholestasis, previous cesarean sections or myomectomy, women with medical condition potentially impacting on the fetal should have the individualized care plan agreed with their obstetrician. So these are the situations where you need a continuous monitoring. Regarding the fetal condition, if you see it's a IUGA baby or small for gestational age, prematurity, that is less than 37 weeks of gestation, post-maturity more than or equal to 42 weeks of gestation, oligohydramnios, abnormal umbilical artery Doppler velocimetry, rhesus isoimmunization, multiple pregnancy or breech presentation, they need a continuous monitoring of CTG. So when we see the CTG, so we already know that we need to follow the Dr. C. Bravado. So now I'm going to discuss about the fetal heart rate. What are the things we actually look on the fetal heart rate? So fetal heart rates, as I mentioned, that we see the baseline heart rate. So that means if you see these pictures and if you make a straight line over the baseline over the maximum fetal heart rate, then you will get a baseline. So that means that going to exclude any kind of acceleration, that going to exclude any kind of deceleration. So in this case, you can see that is overall baseline is 120 beats per minute. Next is we see the variability. So how we going to calculate the variability? So when we calculate the variability, we always measure the upper and the lower limit of the baseline heart. If we subtract the upper and the lower margin of the baseline heart, that is the variability. That means you can't calculate the acceleration or deceleration. You only need to measure the upper and the lower limit of the baseline heart. So here you can see the upper limit is 130 and the lower limit is 110. So the baseline variability is actually 10. Okay, so this is the way we calculate baseline variability. So the normal variability is actually 5 to 25. Reduced variability means that if it is below 5, any kind of absent variability or in that situations, we can say it's more than 25 beats per minute. Now let's talk about acceleration. So acceleration means that when there is a rise of fetal heart rate more than 15 beats per minute and is persists for more than 15 seconds, that indicates acceleration. Okay, so if any CTG, if you see that there's an acceleration, so that's also a reassuring sign. So this is the things we follow. The next thing is that we see the deceleration. So deceleration means that if you see that there is any kind of slowing of the fetal heart rate more than 15 beats per minute and it persists for more than 15 seconds, so that indicates this is deceleration. Okay, so when we see the deceleration, always we see what type of deceleration it is, whether it is an early deceleration, whether it is a variable deceleration, whether it is a late deceleration, or whether it is a prolonged deceleration. Okay, so early deceleration, late deceleration, and the variable deceleration, always it's this type of things. They are classified based on the relationship with the uterine contraction. Okay, so for an example, if you see that any deceleration that's starting its peak and is ending coincide with the uterine starting peak and ending of the contraction, that indicate it's a early deceleration. And usually early deceleration we see in the late first stage of the labor or in the second stage of the labor because of the head compression that stimulate the vagus nerve that can slow down the fetal heart rate. So always you will see early deceleration in the late stage of the late first stage or the second stage of the labor. So that's actually normal or it's a reassuring features. Okay, so the next is that late deceleration. Late deceleration means that the easiest way you can say it's a late when you see that it's starting, ending, and its peak is later than uterine contraction starting, ending in peak, almost like 15 beats per minute later. In 15 minutes later, 15 minutes later, in that case, we can classify it as a late deceleration. So late deceleration means that when it's occur later than uterine contraction, then we term it as a late deceleration. Late deceleration is always a no abnormal features or a pathological CTG because late deceleration only we see if there is any kind of uteroplacental insufficiency. So when there is a fetal hypoxia or uteroplacental insufficiency, in that case you will see late deceleration. Next is variable deceleration. Variable deceleration means that is actually variable. That means there's no relationship with each of the deceleration, and there's also no relationship with the uterine contraction. This type of deceleration we call variable deceleration. Variable deceleration usually occur if there's any kind of cord compression or any kind of cord prolapse. So when you see the variable deceleration, there are few things we see. So a variable deceleration, what are the few things we see? When we see the variable deceleration, always we try to find out whether there's any concerning features or there's any non-concerning features. So there are certain criteria, if you see in the variable deceleration, that we term it as a concerning characteristic. If you see the variable deceleration lasting longer than 60 seconds, that is one of the concerning characteristic. With the variable deceleration, if you see there's a reduced variability, that's also one of the concerning characteristic. If you see that after a variable decels, it's failed to return to the baseline, that's another concerning characteristic. If you see that the deceleration is W shape, or there is no shouldering. Shouldering means that when the starting of the ending of the variable deceleration, usually always there is a slight rise of the fetal heart rate. So that is called shouldering effect. So that's also one of the reassuring things. So if you see that there's no shouldering, that's also a concerning characteristic. So when you see the variable deceleration, always you have to look on whether it is concerning or non-concerning. Concerning means that the one thing is that if you see that it's lasting longer than 1 minute, second is that along with the reduced variability, third is that if you see that there is a failure to return to the baseline, fourth is that if you see it's a W shape deceleration, or if there's no shouldering effect, then we can term it as a variable deceleration. So this is all about the deceleration. Sometimes we will see a single prolonged deceleration, like more than, it can be longer than 90 seconds, but less than 5 minutes. That is we call prolonged deceleration. Sometimes we will see a sinusoidal pattern. That means there will be no acceleration, no deceleration, only bit-to-bit variability like 5 to 15 minutes. Okay, so usually sinusoidal pattern you will see if there is any kind of fetal anemia. So here you can see every 10 minutes you will see this type of marking on the CTG, so that you can calculate the number of contractions. So you can see there is a 1 and 2 contraction. So 2 in 10 minutes there's a contraction. And then as I mentioned that you can see that here in this CTG tracing is like 60, 70, 18. That means in y-axis is a 10 beats per minute, and x-axis you can see that is this broad line is actually 1 minute. So 1 minute, 2 minute, 3 minute, 4 minute, 5 minutes, 6, 7, 8, 9, 10. So every 10 minutes you will see this type of marking, and this broad marking is actually 1 minute. So that means this is 30 seconds and this is 1 minute. Okay, so here you can see that if you pass a straight line, and you can see the baseline heart rate, that is actually, if you see, this is 120 beats per minute. And then here you can see, you can measure the bit to bit variability. So that is the baseline bit to bit variability. So upper limit and the lower limit. Upper limit is in 130 and lower limit is 115, like that. So it's actually 15 bits per minute. So as I mentioned that if there's any rise of fetal heart rate more than 15 beats per minute, persists for more than 15 seconds, so that is acceleration. So our baseline here I can see is 120, and the rise of fetal heart rate is like nearly 150, and it persists for more than 15 minutes. So almost like 1.5 minutes. So that is one of the acceleration. This is another acceleration. Okay, so the next is that deceleration, early deceleration. So here you can see that there is a slowing of the fetal heart rate, and it's coincide with the uterine contraction. So these are the early deceleration. The late deceleration, here you can see that it's later than the uterine contraction. Every deceleration is later than the uterine contraction. So these are the late deceleration. Variable deceleration, you can see that there is a no coincides with each of the deceleration, and that is also not coincide with the uterine contraction. So these are the variable deceleration. And as I mentioned that the reduced variability, so bit to bit variability should be 5 to 25. If any point, if you see that is below 5, then you can term it as a reduced variability. And this is the example of a prolonged deceleration. So you can see this is a prolonged deceleration. And you can it is persist like 1 minute, 2 minutes, 3 minutes, 4 minutes, also almost persist like 4 minutes. And this is the sinusoidal pattern. You can see that there's a no acceleration, no deceleration, and this is almost a sinusoidal pattern. Usually sinusoidal pattern you will see in case of fetal severe anemia. So here you can see these are the examples of the deceleration. So early deceleration, as I mentioned, that it will be coincide with the uterine contraction, and mostly it is occur because of the head compression in the first stage of the labor or in the second stage of the labor that can stimulate the baroreceptor, and that can cause slowing of the fetal heart rate. The variable deceleration, you can see that they are not coincide with the contraction, and they are variable. That means there's no relationship with each of the deceleration. So that usually occur with the cord compression or cord prolapse. Okay, late deceleration, you will see that they actually start end later than the uterine contraction, and it is associated with the placental insufficiency. And you can see that there is also a prolonged deceleration, and here it persists 1, 2, 3, 3 minutes, nearly 3.5 minutes. So it's also because of the placental insufficiency. Okay, so now these are the examples of the variability. You can see here it is variability is nearly 5 to 10. So reassuring features is that if it is 5 to 25. Non-reassuring is that if you see it is less than 5 beats per minute for 30 to 50 minutes. So that means if you see there is a reduced variability, in that case you can wait up to 50 minutes. That means up to 1 hour you can wait, because up to 1 hour it's normal, but after that it becomes suspicious. Or if you see that there is a variability more than 25 beats per minute, like this is the example of that. If it is persist for 15 to 25 minutes, so that is we call saltatory pattern. So that is also non-reassuring. Abnormal is that if you see that there's a reduced variability, like a straight line for over 50 minutes, that means almost more than an hour. If there's a reduced variability, that is abnormal. And more than 25 for more than 25 minutes, or any kind of sinusoidal pattern, that is also we term it as an abnormal. We will discuss more details in the WHO classification. So I again repeat, when we see the fetal heart rate on the CTG, that is the CTG term, when we term anyone asks you about to classify the CTG, always you have to follow the Dr. C. Bravado. So first is that you have to identify the risk over there, then the contraction in 10 minutes, then baseline rate, then variability, then acceleration, then deceleration, and then overall assessment, and followed by your plan of management. So this is the WHO classification nowadays we are following. And you can see that based on the, this is actually the intrapartum monitoring. So in intrapartum CTG and the antepartum CTG is a bit different. Intrapartum CTG, we actually classify them based on the three things. So that is, one is the baseline heart rate, second is the variability and the deceleration. We don't calculate the acceleration here. But if it is an antenatal CTG, in that case, we include acceleration. So this WHO classification is basically on the intrapartum monitoring, that is the intrapartum CTG. And in your exam, they're going to give you the questions mostly related to the intrapartum CTG. They will not give you any questions related to antepartum CTG. Okay. So in intrapartum CTG, always remember that's based on the baseline heartbeat, variability, and the deceleration. It will not include the acceleration. Okay. So basing on these three things, we can classify them as a reassuring, non-reassuring, and abnormal. So regarding the reassuring, in case of a baseline heart rate, you can see there is a heart rate should be 110 to 160 beats per minute. That is the normal reassuring baseline heart rate. Non-reassuring, if you see that it's 100 to 109 or 161 to 180 beats per minute, that is non-reassuring. Abnormal, if you see it's below 100 or more than 180 beats per minute, that is abnormal.
So always remember 110 to 160 is the normal, and then non-reassuring up to 100 or up to 180 is normal, abnormal below 100 or above 180 beats per minute. Regarding the variability, as I mentioned, 5 to 25 is normal. Non-reassuring, we already mentioned, less than 5 beats per minute, that means reduced variability up to 50 minutes is non-reassuring. More than that, that is obviously abnormal. Regarding more variability, like more than 25 beats per minute is for 15 to 25 minutes, that is non-reassuring. More than 25 minutes, that is abnormal. Or if there is any kind of sinusoidal pattern variability, that is also abnormal. So this is abnormal. So always remember up to 50 minutes, that is non-reassuring, reduced variability, and up to 30 minutes or up to 25 minutes for more than 25 beats per minute, that is non-reassuring, but more than that, that is always abnormal. Regarding the deceleration, we already know that we can see three type of deceleration. One is early, one is variable, one is late deceleration. So regarding the variable deceleration, so we already know that when we see the variable decelerations, we have to see the concerning characteristic, whether there's a, like, you have to see whether they are lasting longer, more than 1 minute, whether there's any reduced variability, whether it's failed to return to the normal baseline, or if it is a W shape or biphasic pattern, or there's no shouldering effect. So these 5 patterns also you need to look on when you see there's a variable deceleration. So regarding the reassuring, if you see that there's no deceleration or early deceleration, that is reassuring. Regarding the variable deceleration, if you see that there's no concerning characteristics, less than 90 minutes, that means 30 minutes, 1 hour and 30 minutes. If you see that there's a variable no concerning characteristic, that is reassuring. But more than that, like more than 90 minutes, that is non-reassuring first thing. But if you see any variable deceleration with concerning characteristic, in that situations, you have to see whether it is associated with up to 50% of the contraction, or it is associated more than 50% of the contraction. If it is up to 50% of the contraction for 30 minutes or more, that is non-reassuring. But if it is over 50% of the contraction less than 30 minutes, that is also non-reassuring. But if you see that it's a very repeatedly variable deceleration is coming with the concerning characteristic less than 30 minutes, that is non-reassuring. More than 30 minutes, that is obviously abnormal. Okay, but if you see that it's coming up to 50% of the contraction, that means not that much frequent enough. For 30 minutes, you can wait, 30 or more that you can wait. Okay, so this is non-reassuring. Abnormal is that, as I mentioned, that if you see there's a repeated variable deceleration with concerning characteristic 30 minutes or more, in that situations, obviously that is abnormal. If you see any point there is a late deceleration, that is obviously abnormal. Any acute bradycardia when there is a single prolonged deceleration 3 minutes or more, then that is also abnormal. So always think about that. If there is any late deceleration, any acute bradycardia, obviously that is abnormal. Non-reassuring, if you see any variable deceleration without concerning features more than 90 minutes, with concerning feature, if you see up to 50% of the contraction, 30 minutes or more, but if it is coming more frequently, that means over 50% of the contraction, less than 30 minutes, that is non-reassuring. In case of reassuring, if you see there's no deceleration or early deceleration or variable deceleration, no concerning characteristic, less than 90 minutes, that is also reassuring. So when you see there's an reassuring, non-reassuring, abnormal, then you have to categorize the CTG. So whether the CTG is normal, whether the CTG is suspicious, whether the CTG is pathological. So how are we going to classify or categorize? If you see that there's all features are reassuring, that is normal. If you see that there's one non-reassuring and two reassuring, that is suspicious, because we are basing this CTG on the by three things we will look on that. One is the baseline heart rate, one is the variability, one is the deceleration. So if you see there is only one non-reassuring, but other two are reassuring, that is suspicious. Regarding the pathological, if you see there is one abnormal features or two non-reassuring, that is pathological. So if you see one non-reassuring, that is suspicious. But if you see one abnormal features or two non-reassuring features, that is also pathological. So now you know about that. You can classify that is a normal, suspicious, or pathological. So what is your next steps? In case of normal, then you can just monitor the patients. You can assure the woman and her birth partner about that. But if any point, if you see it's a suspicious, in that case, you have to find out any acute events. So what are the acute events? You can find out whether there is any hypotension, whether there is any uterine hyperstimulation. Okay, so then you can do some conservative management, like you can give her some fluid, you can tell her to change the position. These things you can tell, and you can inform the obstetricians or senior midwife to come and see the patients. So these things you can tell, and you can also inform the woman and her birth partner about the situation. So that is you can do on the suspicion. That is just only the conservative measure, and then can review the CTG later. In case of pathological, obviously you have to inform the obstetricians and the senior midwife. So why they mention obstetrician? Because usually the CTG monitoring is done by the midwife. So when the midwife see that the CTG is pathological, so always they need to inform the senior midwife or the obstetrician. And then you have to look out the acute events like any kind of abruption, rupture, or cord prolapse. If you see any kind of problems, then always you have to look on these things, like whether there's any cord prolapse, whether there's an abruption, whether there's any scar ruptures. And then you have to find out any kind of underlying causes like hypotension or hyperstimulation. Then you can give some measurements, like give her fluids, changing the positions, talk to the woman and the parents partner about the situation, and then you can review the CTG. If you see that the CTG is still pathological, in that situations, you can do a digital scalp stimulation. Always remember in your exam, before doing any fetal blood sampling, always do the FBS first. That is the fetal scalp stimulation. Okay, so this is the first thing you can do. And if you see that after fetal scalp stimulation, still the CTG is pathological, then two things you can do. Either you can do the fetal blood sampling or you can expedite the delivery. Okay, so these two things you can do over there. Okay, so in case of pathological, find out the acute event, find out the underlying cause, either hypotension or hyperstimulation. Do some conservative management like IV fluid, change the position. If she's on syntocinon, then stop the synto for some point and review the CTG again. If you see they're still pathological, then do the fetal blood sampling. If you see that is still pathological, in that situations, you can consider two things, that is the fetal blood sampling or you can expedite the delivery. These things you can do in case of pathological CTG. But if any point, if you see that there's an acute bradycardia or a single prolonged deceleration for 3 minutes, in that situations, you have to expedite the delivery. Okay, so always you have to rule out in case of acute bradycardia, that is the rule of 3. Okay, so always think about that if there's any cord prolapse, scar ruptures, or placental abruption, hypotension, hyperstimulation, whether these are over there or not. But for the first 3 things, always you have to go for category 1 cesarean section. Usually we divided the cesarean section 3 way. Category 1, then you have to do it within 30 minutes. Category 2, that you can do it within 1 hour. But category 3 is that that you can do it within 24 hours. And category 4 means that this is the elective case. So if you see that there is any 3 of these things over there, like cord prolapse, scar ruptures, or abruption, go for category 1 cesarean section. In case of acute bradycardia, always you have to think about rule of 3. Rule of 3 means that if you see that it persists for like 3 minutes, in that case, you can pull the emergency buzzer. That means you can call for help. You can do the conservative measures, like you can change the position of the mom. You can give her some fluid. You can stop the syntocinon over there. So that is done within 3 minutes. By 6 minutes, you can identify the cause. If you see that there's any acute event, go for category 1 section. If iatrogenic cause, diagnose, immediate measures must be utilized to correct. These include, you can stop the symptom if there's a propase. That means this is a induction process we do. You can remove the propase. You can administer the tocolytics. You can start the IV fluids. So these things you can, if you see any acute event over there, that you can correct that over there. Like you can stop the symptom, you can remove the propase, you can give her tocolytis if there's an hyperstimulation, or you can give her some fluids. That 6 minutes gone. By the 9 minutes, you have to move to the theater. If no sign of recovery noted, then you have to prepare for delivery. By 12 minutes, you should delivery should have commenced. By 15 minutes, baby should be delivered within 12 to 15 minutes of acute bradycardia. Okay, so always think about this rule of um, rule of 3. By 3 minutes, pull the buzzer. By 6 minutes, do some conservative management. 9 minutes, move to the theater, deliver the baby within 12 to 15 minutes. Okay, so this is called rule of 3. Okay, so this is for the acute bradycardia or single prolonged deceleration for 3 minutes or more, what you can do. Always remember, within 9 minutes, move to theater, delivery within 12 to 15 minutes. So how are you going to deliver the baby by 12 to 15 minutes? If you see that still there's a bradycardia, tell your anesthetist do the GA, because sometimes spinal or epidural can take time. So they can do the GA and you can immediately then and then deliver the baby. So this is happen in case of acute bradycardia. Okay, so this is all about the CTG tracing. You will get a different type of question. They will give you a scenario. They can ask you about the diagnosis. They can ask you about the management. Mostly in case of part 1, they can ask you about the diagnosis. That means what is the CTG tracing test? What is the category of the CTG tracing? So they can ask you this type of questions in part 1. In case of part 2, they will ask you about the management. So let's see a few questions over there. So this is the first questions. You can see this is para 1. Spontaneous labor at 39 plus 1 week gestation being monitored by CTG because of the raised blood pressure. She has a history of chronic ITP, that is immune thrombocytopenia. She is 4 centimeter dilated, draining like her on the admission, and progressed 8 centimeter in 4 hours. That means initially she's 4 centimeter dilated and she is shrunk, and then she progressed to 8 centimeter in 4 hours. So that's quite good things. CTG baseline is 145 minutes. That's normal. Variability 60 beats per minute, but 50% contraction in lasts for 30 minutes. So that means that we can term it that if the variability is like, if you see that variability is 60 beats per minute, that means more than 25 beats per minute, and it's lasting for 30 minutes. In that case, that is actually we can term it as an abnormal. So one abnormal, we can term it as an pathological. Okay, because if you go over there, if you see that variability, if it is more than 25 beats per minute, and if you see that it persists for more than 25 minutes, in that case, that is abnormal. Any abnormal features, then we can term it as a pathological. So in this situation, then what they did, then woman is already an IV fluid, change in the position. You are called to review the CTG. So what is your first of action? So what you're gonna do? Delivery by the cesarean section, fetal blood sampling, fetal scalp stimulation, IV fluids and change of position, no action needed. So the first thing, as I mentioned, if it is abnormal, what we're gonna do? We can do the conservative measure. If it is still abnormal, in that case, the first thing we do the digital fetal scalp stimulation. So the answer will be the fetal scalp stimulation. And if it is still persistent, then we can think about delivery of the baby. So or fetal blood sampling. So in case you can see the patient is suffer from chronic immune thrombocytopenia. So baby might have this immune thrombocytopenia. So in that situation, the next steps can't be fetal blood sampling because there is a higher risk of bleeding from that cut, because the baby might suffer from that chronic ITP. So you never know. So you can't go for a fetal blood sampling. In that situation, it's better you can go for delivery by cesarean section. Okay, so always think about the scenario and then answer. So here the first thing is that I can see that the CTG is abnormal, as because the variability is very high and it persists for 30 minutes. And in that situation, first step we can do, they did the conservative management already. So we can do the fetal scalp stimulation. And if it is still abnormal, in that case, we have to consider cesarean sections. We can't do the fetal blood sampling. Why? Because mom is suffering from chronic ITP. So baby might have that also. So we can't take that risk over there. The next question is, the primiparous woman, 33 plus 4 weeks of gestation, is admitted in labor at 11:30 and was found to be 3 centimeters dilated. Fetal head is -3 station, rupture membrane, draining liquor at 13:20. That means like just like a 2 hours later. And we were called to review the CTG at 14. Okay, so 11, 12, 13, 14. So that means just 3.5 hours later, you can see the baseline heart rate is 150. That is okay. Variability is 3. Variability is reduced. There is no acceleration, but there is a variable deceleration more than 60 beats per minute, lasting for more than 60 seconds for the last 25 minutes. So we know the variable deceleration, this is concerning because there's an also reduced variability. Because we know that there's a 5 criteria. If it is present, then we can term it as an either of these present, then we can term it as an concerning features. So we know that the variable deceleration with these concerning features, it is persists for more than 60 seconds and it is occurring in more than 60 beats per minute. So if you see that if this situation, if it is coming very repeatedly and it is persists for more than 30 minutes, so that is termed as an abnormal. So in this situation, this CTG is actually pathological. Why? As because the variable deceleration with the concerning characteristic, because the reduced variability is persists for more than 15 beats per minute, 60 beats per minute. That means it's coming more frequently, more than 30 minutes. So that is lasting for 35 minutes and almost like every contraction it is coming. So that indicate the CTG is pathological. Okay, so vaginal examination you did and you see that 5 centimeter dilated blood stain liquor. So blood stain liquor can indicate it might be an abruption and your CTG is pathological, then you have to go for delivery. So you have to expedite the delivery by category 1 cesarean section. So this is the way you will get the questions and you have to find out what is happening. What is the category of the CTG? And what is the scenario actually try to explain you over here. So here you can see the first thing is that she is a baseline heart rate is fine, variability reduced, no acceleration, variable deceleration, more than 60 beats per minute, lasting for more than 60 seconds. Last 35 minutes is coming with every contraction. That means more than 50% contraction, persistent for more than 30 minutes. So that means it's an abnormal features. In a abnormal feature, make the CTG pathological. With the pathological CTG, now she's only 5 centimeter with blood stain liquor can indicate an abruption. So you need to expedite the delivery by category 1 cesarean section. So this is all about the CTG. This is only the part of the labor word that is a bit critical and is difficult to answer for you. So that's why I make it a separate things. I will in my next session I will discuss with the labor word module. That is how you're gonna answer the labor word questions over there. Please, if you have any questions, you can comment on the comment box and I'm happy to answer over there. If you have any query, you can also ask me the questions related to the labor and delivery modules on the MRCOG Health group. I'm also happy to answer all the questions. And if you get updated about our videos, then you can press the like button and also press the subscribe button. Thank you.
This conference will now be recorded.